Hello, friends of the Retina Channel podcast. Welcome to another episode of this series. I'm Dr. Kevon Kushan from Toronto, Canada, and today we have a surgical episode for you on an article that was published just lately by my new colleague at Toronto Retina Institute, Dr. Jong Park, is here with us today, and he's going to talk to us about an analysis of different methods of closure of macular holes that are associated with macular telangiectasia. It's a very niche type of disease, macular holes in association with macular telangiectasia, but something that's overlooked. And I personally thought about how many of these I might have missed in my personal practice, and thankfully I learned more from his research and this wonderful article. So Dr. Jong Park, our guest today, he grew up in Toronto, Canada. He did his undergrad university at the University of Toronto. He did medical school at Duke University School of Medicine. And then he did the Howard Hughes Medical Institute Research Fellowship at Genetics at Boston Children's Hospital and also Harvard Medical School. He did his ophthalmology residency at Stanford University School of Medicine. And then he did his vitreoretinal surgery fellowship at Associated Retinal Consultants at Beaumont Hospital in Royal Oak, Michigan. So he's gone to all the right schools, and he's been to wonderful places and been exposed to wonderful mentors. And this article he's talking about today comes from his fellowship. He won a very significant award for this article not too long ago. And we are thrilled to have him back in Toronto working with us at Toronto Retina Institute. And I'm thankful that he could give me his time out of his busy schedule with patients and his young family and teach us about this publication. Without further ado, let's start the conversation.
Hey,
Hey, John, how are you?
good. How's it going?
Very good. Welcome to Retina Channel podcast.
Thank you so much for having me. I'm excited.
It's a pleasure to have you. I'm excited to see you here on the channel. Congratulations on this article you just published with your group. It's a multi-center global study, so that's amazing. And and then I know you recently won an award for it, right? Margeria Retina Society Research Award. So before this was published, so congratulations on that as well.
Thank you very much. Thank you.
I want to tell our audience that you are a new retina specialist here in Toronto with the Toronto Retina Institute. So we are excited to have you on board. As a wonderful, brilliant ophthalmologist and retina specialist. So it's amazing to have you here with us at TRI and also here on the channel.
Thank you. Yeah, I couldn't believe I was the first one to be invited from the group, so it's a real honor.
Yeah,
And
others have been invited. It's just sometimes hard to catch them.
I'll make sure to rub it in that I was first
Yeah.
to the podcast.
Yeah. Well, yeah, I think the principal investigator of the study you just published, Dr. Mahmoud, has been on the podcast, and he talked about his autologous retinal transplant technique, and that was a fascinating episode as well. And then, so that's a nice segue to your current publication. And the title of the study that I think it just came out in the Blue Journal in Ophthalmology is called The Surgical Management of Full Thickness Macular Holes in Macular Telangiectasia Type 2. It's a global multi-center study. And if that's okay with you, I'll just give a gist of it to the listeners and the viewers, and then we'll just delve into the details with you.
Mm-hmm.
So you have lots of people involved in the study. And you collected a cohort of patients. I think you had 63 or so, if I'm not mistaken, patients, or you correct me if I'm wrong later on, who all had macular hole surgery. And that was because of a full thickness macular hole associated with macular telangiectasia. And then you kind of divided the group into three cohorts, people who had surgery using an ILM peel, people who had an ILM flap, or people who had an autologous retinal transplant. And you kind of compare the success rate among all these three groups, vision changes, in terms of improvement, and you have some nice suggestions towards the end. That sums it up okay?
That basically sums it up.
All right. So, my friend, um, so let's talk about some basics first before we get into your study. Um, could you tell us for just listeners and viewers, what is macular telangiectasia type 2 and how common is it to cause a full thickness macular hole?
Yeah, it's a great question. So it's kind of looking at commonality. I would say macular holes are something we all deal with as retina specialists, fairly commonly. And then MacTel, it's not it's not uncommon for us to deal with as retina specialists. And you were asking what it is, and for some of the residents on the podcast maybe, but it's essentially a condition that affects the blood vessels and also kind of sort of the more recent thinking is the Mueller cells, so possibly a
Mm-hmm.
neurodegenerative process. But phenotypically, a lot of the early descriptions of MacTel were based off of these venules, like right angle venules you might learn for boards, for example, these telangiectasias, these sort of cavitations and pigmentary crystalline changes sort of in the temporal macula, temporal to the fovea. And then on OCT, classically, you would see these cystic cavitations, again, very much sort of in the temporal part. Um,
Mm-hmm.
and there were some, a lot of different classifications over the years. Dr. Gass, Dr. Blody, and others really kind of looking at the phenotypes and type 1, type 2, type 3, there are all these things, but sort of the more modern classifications are based off of imaging findings. And we in our study focused on the most common one, which is sort of broadly speaking type 2, generally a bilateral process. And again, sort of what we typically view, if you see it in clinic, it's probably going to be the type 2, these sort of temporal cystic changes, pigmentary changes. And then just going back to your original question, macular holes in MacTel is actually very rare.
Mm-hmm.
It was actually only first described in 2005, 2006, even though we've known about MacTel for much longer than that. And it's quite uncommon.
Mm-hmm. Mm-hmm. Yeah, I remember CNV associated with MacTel is something that we think more about and even treat sometimes, but I have to admit, macular hole associated with MacTel, they're probably missed very often. I might have missed some Mac holes that I might have been related to MacTel. This article has actually makes me think about now. Look at every Mac hole. Maybe there's some MacTel features about it.
It's
Yeah,
possible I probably missed some too. So
yeah. So, how did you come around and collected all these centers? How many centers did you have, Jong? And how many continents or countries?
yeah, so it was a really, collaborative effort. I was very lucky to be part of this network, and a lot of these surgeons are extremely accomplished and are known for doing challenging surgeries. So, one of my mentors, as you mentioned, Dr. Tamer Mahmood, is one of these surgeons, and he reached out to sort of a large network of fellow outstanding surgeons who do these tough cases. They see a lot of cases, they do a lot of cases, and we were really, really lucky to involve such an esteemed group. I can't take much credit for that, and I was just very, very lucky and privileged to be part of that. It involved folks in, Asia and North America and Europe and Middle East. So. It was a really it was great collaboration.
You're very humble, Jong. As the first author of the study, I'm sure you've done a lot of work on this. Uh, so, Let's talk about it. So those three groups that I mentioned, could you maybe discuss more about them? Majority were in the ILM peels, I imagine, and maybe if you could sort of talk about those three groups individually and what techniques were more or less used in each group, and the success rate, just in broad strokes, so for us to remember something.
Yeah, definitely. Yeah, the majority of the surgery. So we looked at there were 63 surgeries in total. Some of these were re-ops, or some patients had bilateral surgery. But looking at all the surgeries, a number of cases, there were 63 of them, and the majority, 34 of them, were ILM peeling alone.
Mhm.
And we didn't, standardize in terms of how much of the ILM was peeled, and things like that. But we did look at some of the factors, what gauge vitrectomy was used, what stain, what kind of gas, the lens status of the patient. So we kind of went into the weeds a little bit there. But broadly speaking, the most common surgery that was performed was island peeling alone.
Mhm.
And and then we kind of looked, the next biggest group was ILM flaps.
Mhm.
And again, we didn't standardize in terms of what kind of flaps, where they were taken from, the quadrant or hinged or not, or all of these things. But, in the literature, ever since this was described, the flap technique, there have been a lot of great studies looking at other types of macular holes, myopic holes, holes with detachment, idiopathic holes, of course, and comparing the two techniques, peeling versus
Mhm.
flap. So we thought this was very kind of a good way for us to approach the topic. And then
Mhm.
we were lucky in that Dr. Mahmood has done some autologous retinal transplants for these, as well as some of our collaborators as well,
Mhm. Mhm.
who just really went for it and did the ART for these holes. And so those are the three biggest groups. There was one technique of a retinotomy, like a relaxing retinotomy technique, and then one also using a subretinal bleb. And these were also described with some success in other types of macular holes. And so
Mhm.
we included those as well. But those were the three groups, and I'm happy to kind of go into the numbers if you'd
Yeah,
like,
let's
or
talk about it. Like the first group, the main group, and majority patient, they had an ILM peel. So let's talk about their success rate, if the vision was any improved before, after failure, things like that. Yeah,
Yeah,
please.
absolutely. There were, for the island peels, there were 34 of these, and
So 34 surgeries out of 63 were ILM peels, which is
correct.
what we do generally for a lot of my calls. Yeah.
Exactly.
Yeah.
And most of us, for these smaller, like idiopathic macular holes, we do the island peel, and most of us are used to, a very good success rate. But the one of the kind of background questions for our study was, when we looked at the literature, not, these are pretty rare, but the closure rates that were reported were extremely low.
Mhm.
Around, if we look at all the case series that were published, it was only around 30% successful closure, as opposed to many of us 90% plus for,
Yeah.
these more smaller idiopathic holes.
Yeah.
So that was kind of one of the background questions, is the success rate really so low? What's going on? What can we, learn to try to improve that?
Mhm.
So the island peeling group, when we looked at just overall, we kind of divided them further into primary surgeries and refractory holes, but just all comers, anyone with a MAC-TEL macular hole, if you got an island peel, your whole closure success rate was 47%.
Mhm. Just
So
about 50, just under
mhm,
50%.
exactly.
Okay. Okay.
Um,
And then this was regardless of type of gas used or whether what kind of staining was used or not, correct? It was between gas tamponading agent didn't matter and the
yeah, it's a great
staining agent
question.
didn't matter. Yeah.
Yeah, it didn't matter. It was about split pretty evenly, SF6, E3F8. I think more folks used ICG than tissue blue or some other stains.
Hmm.
But none of those were statistically significant, one way or the other.
Hmm.
And then
in this group, the holes were not particularly large holes, right? There was a range of holes, right? In terms of
yeah, there was
sizes.
a pretty large range of holes and a large range of sort of visual acuity, preoperative visual acuity, and this is one of our limitations, just sort of retrospective study, large, data set, different surgeons, but the range was fairly large. Some were like tiny holes, like 50 microns. Others were over 1,000 microns. And actually, all the groups, when we go through them, there was pretty large range. Although jumping ahead a little bit, the ILM flap group, those holes were actually larger on average than the ones that folks did ILM peels, and I think most of us intuitively would probably say, okay, if it's fairly small, maybe we'll just do the peel. If it's larger, maybe we'll need to do something else.
And this may be a difficult question. I'm not sure if you addressed it or not. In this first group, the ILM peel, were the more successful ones the one who were smaller holes, or did it matter, or was there any characteristic within this group that made the surgery more successful or not?
I'm really glad you asked that question. That's one of the questions we were hoping to answer, but just the way the data was collected and the retrospective nature, it was very hard to determine, what preoperative characteristics led to better success in terms of things like the size of the hole. But that's a really great question. It's something that we thought about, but we just weren't able to answer
Weren't
with
able
our
to
study.
answer. But that's like the fact that you were not able to answer would say a lot too. That, if you said, oh, the only small holes closed, then, that could maybe point in a different direction. And this is a sort of an offshoot question. The MAC holes, these generally don't form because of the regular vitreomacular traction causing holes, right? This is a different mechanism of hole formation. Is that correct?
That's the theory that I certainly support, and a lot of smart people have thought about this, but I think that's correct. I think when you look at a lot of these holes, especially serially as they develop, it seems more likely that these cystic cavitations and loss of Mueller cells, especially in the fovea, there are concepts of like a Mueller cell cone in the fovea. As these cells degenerate and get lost, more and more of the retina kind of gets lost, and then you can imagine that can turn into a full thickness hole. None of the studies looking at this have really supported this idea that a vitreomacular kind of force causes these holes. And I think that this is a really a key question for these patients, is perhaps the reason the success rate is so low is that it's a completely different pathogenic mechanism.
Yeah. So if you just bring the edges together, they may not reform a foveal contour because there's degeneration and lack of Mueller cell presence, as you said. But it's an interesting thought.
Yeah, no, this is a very key kind of point in these patients.
Well, let's go to your second group, and these are ILM flaps. So you had a smaller number of patients here and better success, as you mentioned. Could you talk about that, please?
Yeah, absolutely. So of the 63 surgeries, 34 were the island peels, and then 22 of them were island flaps. So a significant number here. Just kind of the punchline here is that looking at all comers, the overall successful hole closure rate using an island flap was 90%. So this was statistically significant, and actually even better than we had expected. The other group was only 47%, but this group had a 90% successful closure rate.
Which is closer to what we're used to for regular macular holes.
Mm-hmm.
And the flap, you mentioned there were different flaps. And do you have any idea? So usually flap, you're thinking about the sort of perifoveal flap, maybe inverted flap, or Well, you said it could have been harvested elsewhere from the retina. Do you have any data on that?
It's a great question. So we did not collect data specifically about where the graft or where the flap was harvested, or there are a lot of different variations now. Some folks will make a certain hinge on one quadrant, or pull it over the hole, or just stuff
Mm-hmm.
it in the hole. All
Mm-hmm.
these things, and so we did not uh, you know kind of control for that. But
Mm-hmm.
an interesting point that we discuss in the paper is, you can imagine that these patients, we're usually seeing these changes in the temporal macula,
Mm-hmm.
and there's some work being done showing that perhaps these Mueller cells or the ILM here may be degenerating faster, for example, and this may influence how the flaps should be done
Mm-hmm.
in specifically these cases where perhaps getting a flap from the temporal side may not be the best idea.
Another good idea. Mm-hmm.
Maybe we want to get a superior flap, for example,
Mm-hmm.
and that's something we do discuss in the paper.
Okay, yeah. So all types of flaps, whether they're just a layover, inverted, or stuffing in, but they had some kind of a flap used to, and then it was 90% success rate anatomically. Did that translate to better vision compared to your first group as well, like better improvement?
Yeah, great question. So I guess let me skip back quickly to the Island Peel group. So those in that cohort, there was no improvement in visual acuity at post-op month 6, which is when we had kind of the best data post-op,
Mm-hmm.
and in those folks, we did kind of subdivide patients who had some vision gain. And so if you had visual acuity gain of at least 2 lines, we kind of subdivided that group, and then vision gain of at least 4 lines. And so for patients who got island peeling, 43% actually did gain at least 2 lines of vision, and 24% gained at least 4 lines of vision. And of the patients who gained at least 2 lines, 90% of them had full closure. And
Right.
then everyone who gained at least 4 lines, 100% of those patients had whole closure. So
Mhm.
even though as a whole group, it was a very heterogeneous group, as you can imagine, as a whole group, in the island peeling group, there was no statistically significant gain in vision. There was this two subgroups, who did gain at least 2 lines or at least 4 lines. So if we
Okay.
compare that with the island flaps now,
So before you
um,
go,
yeah,
Dark Park, so I guess that makes sense because more than 50% failed in the first group. So I guess as a group, they didn't improve their vision, but probably those who closed, they had improvement in vision. Is that right?
absolutely.
Yeah.
Mhm.
Okay. Sorry, go ahead. So for the iron flap group.
Yeah, and then for the flap group, there was actually some, average, again, as a whole group, looking at average visual acuity pre-op to post-op month 6, there was a statistically significant improvement in vision. So looking at sort of Snellen averages, which I always find way easier to understand than logmar. So kind of going from about 2100 or so, or I'm sorry, 2150 ish pre-op as a whole group, the average vision did improve to about 2070,
Mhm.
at post-op month 6. And then looking at again the number of patients who gained at least 2 lines of vision, 56% gained at least 2 lines. And for at least gaining 4 lines, it was 28% of
Mhm.
patients with island flaps
Mhm.
gained at least 4 lines. And all of these patients who gained at least 2 lines or 4 lines with island flaps, all of them had whole closure.
Mhm. Mhm. And the whole group improved because 90% closed anyway.
Mhm.
Okay, wonderful, very interesting. So let's talk about your last group, the ones with the autologous retinal transplant, ATRs. You had, I think, 4 or 5 patients in that group.
Yeah, there were 5 patients here. They had a much, larger holes and worse preoperative vision than for the other two groups. You can imagine these are folks who've had multiple other surgeries, failed multiple other surgeries, large holes. Let's try the autologous retinal transplant.
Mm-hmm.
And there were 5 of these cases. All 5 of them closed with ART.
Mm-hmm.
And the average vision did not statistically, it wasn't statistically significant, the improvement. However, there was a trend towards vision gain. And so as a group pre-op, the average vision acuity is about 2,500, 2,600, something in that range. Whereas at post-op month 6, the average vision was 2,200. The p-value was about 0.08, 0.07,
Mm-hmm.
0.08. So,
Mm-hmm.
there was some trend for
So if you have
sure.
a few more patients, probably would have
Exactly. I think
made
if
the
we had
cut.
another 3, 4 patients, we probably would have hit the statistical significance there.
Mm-hmm. Mm-hmm.
And then of the 5 patients, one of them, so 20% gained at least 2 lines of vision.
Mm-hmm. Those are more challenging ones, as you mentioned. Okay. Um, so as we talked about it, before I talk about your conclusions or our take-home message, makes me wonder the initial diagnosis of these holes is as we talked about initially is tricky, can be challenging. I imagine if you know what you're dealing with, this macular hole is a MacTel associated macular hole. Um, then you may do an ILM flap versus your usual technique of an ILM peel if the difference is so significant, So that makes me wonder about my initial exam of some referrals coming with macular holes. Maybe I should pay more attention. Does it have MacDel features? Was it the other eye that gave it away? How was the diagnosis confirmed in these cases?
That's a really, really excellent point. I think, in some cases it probably was because they had failed a surgery already. And
Mm-hmm.
then the referring retina surgeon may have been saying, oh, something's wrong. They should have worked, but it didn't. I imagine, that might be how some of these are first diagnosed. But you raise a great point. The fellow eye, of course, a lot of these type 2 MACTEL patients have some changes in the fellow eye. A couple of patients in our study needed surgery in both eyes, bilateral surgery for holes in both eyes.
Yeah, yeah,
And yeah, it just kind of goes back to what I learned. My attendings tried to teach me well. The exam and trying to make sure you think outside the box sometimes. If something seems a little different, then taking a couple extra sort of steps and thinking, oh, could this be something else?
yeah. I think you have really raised an interesting point and brought our attention to something that is probably more prevalent than we think. I mean, it's not a very common disease, MacTel, to begin with, but as retina specialists, you see enough. Um, so it's something I think it encourages us to examine a bit more in detail and at least have some kind of suspicion that some Mac holes may actually have features of MacTel and maybe change our normal technique for these cases. So
Yeah, no,
thank
I
you.
agree. Yeah, no, it's and for me, I'm just starting out as junior attending and the challenging holes, for me, I always think of, if they're very myopic or if they of course have an associated RD. But other than that, and those are, we're not gonna, miss that. But this category of very challenging macular holes, like you mentioned, is something that we may all overlook sometimes.
Yeah, yeah. Let's talk about our take-home message. What should we? I mean, we had a good discussion already, but any final thoughts and what we should remember? All these comparison of all the three groups. What should listeners remember from this article?
Yeah. I think one of the questions we wanted to answer just fundamentally was, is it worth doing surgery on these patients? This
Hmm.
is not an easy surgery, technically challenging. If the success rate is so low, before we did the study, success rates of 30%, no improvement in vision, most people would say, it's not worth the risk of doing surgery. Let's just leave these alone.
Mm-hmm.
But I would say that one of the main take-home messages from our study is that a lot of patients can gain vision and that these holes can be closed.
Mm-hmm.
And it's something that that is worth certainly thinking about and discussing with the patient. And then if you do decide to do the surgery, I think another conclusion from our study is that in these challenging cases, instead of doing the ILM peel as the first surgery, we would strongly, consider doing an ILM flap as the first surgery.
Mm-hmm. Wonderful. Well, thank you. I definitely learned a lot from your article. Good work. Congratulations on this very important work. I think it's one of those things that brings your attention to, oh, this does exist. I didn't know about this, so this is fascinating. Thank you very much.
Thank you for having me, and I'm gonna definitely rub it into everyone else at Toronto Retina Institute that I was I was your favorite. I'm your favorite,
You are my
the only one
favorite.
to be on your podcast. It's truly an honor. I'm really honored, and it's been really fun to
But
do
the
this.
honor
Thank you.
privilege was mine, and I'm glad that you could take the time, your family schedule and your work schedule, and thank you for coming on the show.
Awesome. Thanks so
Have a
much.
good night, John.
Have a good night.
Well, this wraps up episode 74 of the Retina Channel podcast. I hope you learned from it and you enjoyed it. I certainly learned from my conversation with Dr. Park, and I want to thank him, his colleagues at Beaumont, and his many collaborators around the world for shedding light on this phenomenon of macular holes associated with macular telangiectasia and different surgical approaches to correct it. Well, holiday season is here. I wish everyone have a happy and healthy holiday season, and hopefully you're getting enough rest to get back to the thick of things in the new year. And until then, I wish you health and happiness.